difficult to give, it's a little scarier to give, and it's generally on a very increased need or emergent type basis. So verapamil and diltiazem are the two common calcium channel blockers that you can give intravenously. Not all calcium channel blockers can you give IV, okay? All of them you can give PO. One of the more common beta blockers that you can give intravenously is metoprolol or Lopressor. This is a very highly tested medication. Lowers the blood pressure, lowers the heart rate. One of the most common uses for Lopressor, specifically in the cardiac intensive care or post-cardiac surgery, is for patients who have gone through either open heart surgery, probably brought on by a myocardial infarction, or who just had a straight MI. When you have an MI, the heart is stunned. It may be diseased, but it's going through a very traumatic scenario because it just had a heart attack. So to help that heart rest, it's recommended that we put them on beta blockers. That's going to lower the heart rate. It's going to decrease the myocardial contractility, so we're not contracting as hard. It's going to try to rest the heart. At the same time, it's going to open up the vessels, specifically the aorta. So for every time that sick or stunned heart contracts, it doesn't have to push against as much resistance. So it's helpful in cardioprotective or helping that heart recover from the stun scenario it was just gone through. It's actually considered medical malpractice now, based on multitudes of research studies, to not put a patient post-MI on a beta blocker, assuming, of course, physiologically they can handle that. And what do I mean by that? This is what you need to know. What do I mean by as long as your patient can physiologically handle being on a beta blocker? Heart rate and blood pressure. As long as they have an adequate heart rate, which needs to be what? At or above 60, and an adequate blood pressure, meaning systolic at or above 90. Good. That's where your decision making comes in. Okay? So this is very, very commonly used in a lot of areas of intensive care, but specifically with cardiovascular intensive care. And the most common beta blocker given intravenously, if we have to give them a beta blocker for some reason. Of course, we just talked about that. Now, when you talk about sedation, well, you can use sedation in multiple forms. Lots of medications can be used to calm a patient, help them sleep. When we talk about true sedation, where you're going to physically put them into an unconscious state, Precedex and Propofol are the two most common medication used. Diprovan or Propofol is by far the most widely used medication, but Precedex is right behind it. You can pronounce that word. It's all called Precedex. This will stimulate alpha-2 in the central nervous system to elicit sedation, not relaxation, but sedation. Okay? But if we stimulate alpha-2 in the central nervous system, what do we always have to watch for? We just went over. You need to know this. Hypotension. Because again, when you stimulate alpha-2 in the central nervous system, the reason you're doing that is to bring on sedation, not relaxation, but sedation, okay? But at the same time, it washes away the neurotransmitter norepinephrine, which causes vasodilation and could bottom out the blood pressure. So that's the main reason why this medication is like second best to Propofol, because this medication can mess up the blood pressure. But it's a very good sedation. The half-life is very short. It's very dependent on the patient, but it's about 10 minutes to 30 minutes as far as the half-life. So if you need to do a full neurological exam on a patient, you can turn this off, wait about 10 to 30 minutes, and then you can trust that the neurological exam you are doing is truly giving you a good picture of what neurologically the patient's doing. In the past, we used to use Versed. It's a great sedation medication. That's what I want to be on. You writing this down? That's what I want to be on. The problem with Versed is that it takes hours to recover. And you truly, really can't trust the neurological assessment you're getting unless that patient's been off Versed for a good 12 hours. Well, that's not necessarily conducive to keeping a patient in a sedated state, because we want them to be in a very relaxed state, right? We want to wake them up, do a neural, and put them right back under in cases, especially when you're dealing with a traumatic brain injury. So that's why this and propofol have fast taken over the sedation world because of that, the short half-life and the ability to control it from a neurological standpoint, all right? So this is a common medication. Again, that's the big thing that you're looking for, and you can use this for invasive. It's typically not used for conscious sedation, though. For procedures like colonoscopies, etc., we typically don't see Precedex used there. It's really used for a straight sedation scenario, right? But again, propofol or Diprovan. Propofol is the term you're going to hear. Yes, this is the Michael Jackson drug, but he used it incorrectly. He used it straight IV push. You don't do that. Well, you can. As long as you have a CRNA behind your name, you can give it IV push. You don't have a CRNA behind your name, you cannot give this IV push. Did you hear me? You cannot give this IV push. You'll kill them, right? Unless you are in anesthesia or anesthesia's in the room. Anesthesia has to be present if this medication is given IV push, but you can give it continuous IV infusion. That's a very common thing when we're wanting to produce sedation. This is the most common medication now used also for conscious sedation. They very often give a small amount IV push and then start them on a continuous drip if they want to use it for conscious sedation. You know what I mean by that, right? A short-term type of scenario, okay? But it is the most common. Now, the problem with propofan is, number one, it's lipid-based. So what color is it going to be? White, okay? Number two, it's lipid-based. So what's the other problems? What's the problem with the lipid-based medication? Or if you just give straight lipids? Infection, yes. It's fat. It's fat emulsified. It will grow crack very, very quickly. So several things you have to understand. It comes in a very small, either glass or tempered plastic jar. Okay? It can't come in regular plastic because it absorbs it or something. I don't know the chemistry behind that. You cannot let that bag or bottle hang for longer than 6 minutes once it's spiked, because that's the threshold that bacteria will start to grow. So you have to change it out. So it comes in a very small container. We don't usually hang a whole lot. Okay? What?
What do you mean it can't be hung longer than 6 minutes?
The bottle itself, once you spike it, after 6 hours, that bottle has to be discontinued. What did I say? 6 minutes? Oh, shit. Hours. Mark that out. Thank you for correcting me. Wow. Okay, I was on a roll. The bottle can't hang for longer than 6 hours. There you go. The other thing is you have to use strict sterile technique every time you spike a new bottle. Okay? So those are the precautions you have to work. The other thing is it's a lipid base. So fat emboli can occur. Very rarely, but it can occur. So you're always going to be on the lookout for problems with fat emboli. And the most common scenario are chest discomfort, shortness of air where it didn't exist before, if we've got a fat emboli that settles in the lungs. Okay? Very unusual type of side effects, but it is lipid-based, so that is a potential problem. All right? But you will find that most nurses like this drug the best, and then Precedex is right behind it. Okay? Now, there are other types of sedation. We can use Versed, not used very often. And, of course, we can bring out the barbiturates if we want to put a patient in a medically induced coma. Generally, that's because they have a severe traumatic brain injury. We'll talk about that when we get to intracranial issues. Then usually we're going to use the barbiturates. All right, remember back from pharmacology, what's the main side effects of barbiturates?
Respiratory depression.
Heavy, well, yeah, respiratory depression, yeah. Heavy sedation. So if you're giving them a barbiturate, you're usually leaning towards what's called a medically induced coma. These will not produce a medically induced coma. A medically induced coma means that we don't want their brain to be stimulated at all. And again, a traumatic brain injury is the most common pairing with that, because we want that brain to basically be gorked, to let the swelling go down, to not overstimulate that, to not extend the injury, etc. But it will take days for that patient to recover off of medical induced coma, and that's okay. We know that if it's a traumatic brain injury, it may be weeks or months before we can truly get where their neurological status is going to be. So we're okay with that. Every other patient, we're probably not okay with that. We really don't want to put them that deeply into a sedative scenario. So there's multiple different levels and medications we can use for sedation, but these two are the most common, and this is by far the one that's liked the most. Have you had a patient on propofol in another floor? No,
I mean,
you didn't see it when you did your OR? What was
Sit on
it?
the top of ICU.
Well, yeah, they use it like candy in ICU.
I've had it when I had surgery, yeah.
Right, well, you probably have had it, and then when you get old enough, you have lovely things like colonoscopies. You'll have it, okay. But in the ICU, if they're on a mechanical ventilator, they're probably gonna be on this medication, okay? If they're agitated, they're probably gonna be on this medication. If a traumatic brain injury is involved and we don't want them in a medically induced coma, they're probably gonna be on this medication. So you will see it, yes.
I haven't seen it so much in Kentucky, but in Indiana and the ERs, the nurses will give a bolus of this.
You can if it's a
different state
specialized
thing?
order, but anesthesia's on call or on the unit.
ERs, but yeah.
Yeah, they're there, but be careful, that's all I'm saying. You don't have a license to cover you unless it's a specialized blanket order, which probably, because of irritability and people going off the wall when they get in the ER?
Well, it would be, our nurses would give the bolus of it quite often. Our docs would be the ones that push it in the ER and Indiana. And I didn't know if maybe that was a state thing.
It might be that specific ER. Yeah, we can give it, but generally anesthesia has to be there, okay? Because if you give it IV push, that's considered anesthesia. That's not considered sedation. There's a difference between the two and how you're treating it, and it all comes down to regulations. And yeah, Indiana has some different laws than Kentucky does, so maybe, I'm not up on Indiana's laws. But it might be a blanket thing. You will see nurses push this, but again, in Kentucky, anesthesia has to be either in the room or readily available in case you lose the airway. That's the danger of pushing an IV push. And my guess is they're using it on patients who are potentially violent, maybe drug overdoses.
No, this would just be like in any type of code situation where we can just intubate it or we.
Oh, they're using the
resuscitate.
code.
Yeah, well, I mean afterwards, after they're resuscitated and they're on a vent and they're gonna use Diprovan. Our doc would always be in the room, but our nurses would push it.
Oh, yeah, right before they do the infusion.
Right.
Oh, right, they're just getting the levels up.
Right.
Yeah. They're intubated, so you're not gonna lose an airway if they're already intubated. Okay. Give it to me. Push all you want. You got an airway in you, just push the whole damn bottle. No, you don't. but- Okay. All right, so just be cautious, because the dangerous scenarios, that's what the standardized testing likes to test you on, and it comes around with the bacteria issue and the sterilities that you probably, because it is a living based scenario. Okay. So you have this in your book, right? Okay. Now, you don't have it? It's right there. Should be there.
So but it's not on Moodle.
No, I will put it on there, I promise. It's in your, I promise, I will put it on. I just attached a different file. I will put it on there, I will fix that. But it's in your workbook, I promise you. Okay, now when we talk about increased intracranial pressure. Now you can have somebody with increased intracranial pressure or traumatic brain injury on any kind of ICU floor. Some hospitals have specialized neuro ICU. Other hospitals like Jewish have a hodgepodge, so it doesn't really matter where you go because you're going to get a myriad of different types of patients. But when we have increased intracranial pressure, there's a lot of things we can do to lower it. This is, over the last couple of years, based on the new research, this has fast become the first line. It's not really a drug of choice because it is just a hypertonic solution, but that's how it's treated to lower the increased intracranial pressure in the head. What happens when the pressure increases in your head, assuming that you don't have a fractured or removed skull? What happens? If your pressure gets too high, what happens? Brainstem herniation. Your brain has to go somewhere. This skull is not moving unless, of course, it's fractured and needs to move, or we have removed part of it to allow the swelling. But if that doesn't occur, then the brain, when it expands out, eventually it'll start to expand back in and it'll slip down into the brainstem. Okay? What happens if you herniate your brainstem? Actually, you become an organ donor, which would be a good thing if you're an organ donor. So to prevent brainstem herniation, we can treat increased intracranial pressure on an emergent situation. This would be an emergent situation. Okay, there's multiple things we can use, but this has fast become, via the research, the most effective and quickest way to decrease the intracranial pressure. Now, it's a temporary thing, and we don't want to have them on a hypertonic solution for an extended period of time. Why? Because then their electrolyte's going to be way off, affecting what other system? The cardiovascular system. You always have to keep in mind when your electrolytes are completely out of whack and you're in a danger zone, high or low, it's the cardiovascular system and the electrical system that can be detrimentally affected. So we don't want to leave them on this for too long, but this is an emergent situation. What happens is it pulls the fluids out of the individual cells, shrinks them, and that decreases the space they take up, and that's how it decreases the pressure in the head, okay? Now, if we do this, this should be a bridge to some other kind of treatment. Neurosurgery, burr holes, an intracranial pressure monitoring device that can also drain off fluid, removing the skull, whatever it may be, just depending on the type of injury, okay? So when you see hypertonic solution in the ICU, the first thing you think of is increased intracranial pressure. Now there's multiple different solutions, percentage-wise, 2, 3, 5, 7, and 23. It really depends on how aggressive they want to be. The higher it is, the more it will shrink the cells. So that's very patient dependent, okay? You know, normal saline is what? 0.9%, okay? So now we're kicking it up 2 times or up to 23 times the percentage. So that's a very aggressive scenario if you're up here. That's a very traumatic or traumatized brain we're dealing with. You're probably going to be removing part of the skull if that much swelling is taking place, okay? But if you're talking about a high-speed motor vehicle accident where someone was ejected out of a car and not only went through the windshield but hit a tree and then hit a cow which then stepped on them and whatever, I mean, pick your own thing, that's going to be a very traumatically injured brain. That's where the aggressiveness is going to come back. So this is usually a short-term therapy and a bridge to treating however we're going to treat it based on what's going on, okay? So let's see. Okay, so that's just the theory behind it. Well, that's just the